Okay, if everyone could take their seats, we'll get started. So it's a great pleasure to chair this session, which is we all have every session is fascinating at the BMPA, but this is one that's particularly fascinating to me, and it's a pair of linked lectures about interception. And first up, we have Professor Sarah Garfinkel, who's from the Institute of Cognitive Neurology at UCL, close by, having relatively recently moved from Brighton and Sussex University. And she runs a lab there focusing on brain-body interactions, and most of you will be aware of her sort of very high-impact work around interception and lots of fascinating things around sort of somatic mind-body connections. So she's going to kick us off with dissociating dimensions of interception in neuropsychiatry, and then we'll have perhaps a complementary talk afterwards. So thank you so much, Sarah, for coming to talk to us today.
Thank you. It's such an honour to be here. It's a wonderful conference and I'm loving it already. The brain and the body are intrinsically and dynamically coupled. We know that signals from the body can shape the way we think, the way we feel, and also our perceptions. And when we think of senses, we tend to think of things like vision, hearing, smell, taste, and touch. But actually, these can be classified as extraceptive senses. That is, they tell us something about the outside world. And in contrast, we have proprioception, which is the sense of the position of body in space. And we also have interoception. And interoception is a relatively new sense. It was identified in 1906, but the formal definition has been somewhat controversial. Then in 2016, we had an interoception summit where we got together and we came up with a shared definition and wrote a white paper. And this is what we came up with, which is interoception refers to the process by which the nervous system senses, interprets, and integrates signals originating from within the body, providing a moment-by-moment mapping of the body's internal landscape across conscious and unconscious levels. And the particular bodily axis that I focus on is the heart. And my work tries to delineate different dimensions of interoception. So what is interoception? How can we study it in the lab? And at what different hierarchical levels does it operate? And during this talk, I'm going to give you a sort of taster about going through the majority of these levels, just to give an indication on how we might study it and how it might map onto differences in different neuropsychiatric disorders. So I'm going to start off with the afferent signal itself, and then I use very classic measures such as heart rate variability that I'm sure you're all familiar with. And what I find so striking, and it's been known for a long time and it's been replicated many times, is you see these interesting patterns of heart rate and heart rate variability differences in different clinical conditions. And this is a large patient sample that we studied in the lab. It replicates what's been seen previously, which is conditions like schizophrenia have a vastly elevated heart rate. And you see interesting patterns of heart rate variability as well, and that's a variability within the cardiac signal. And schizophrenia, again, is at the opposite end of the spectrum with very low heart rate variability. So the cardiac signal is very regular in schizophrenia. And actually, it's highest in healthy controls, people without any clinical diagnosis, and you see this sort of monotonic decline in heart rate variability in all of these psychiatric conditions. And having a variable heart is seen as an adaptive thing. You want your body to be adaptive and reactive, and it is an adaptive thing. There's just this cool stuff emerging, which is, are these premorbid? Are they a result of the condition itself? And there's some interesting data, longitudinal data, that I found just buried in a table in a JAMA Psychiatry paper in 2016, which is looking at a longitudinal sample of a healthy, initially, population. These were young men, aged 17 to 18, who were joining the army, and they looked at their heart rate. And this was before any symptoms of schizophrenia had come online, and they found an elevated heart rate at age 18 was associated with a greater probability of getting schizophrenia. So there's some emerging evidence that these cardiac differences may actually be predictive or premorbid of the conditions themselves. And I'm doing other work now looking at fine-grained responses like patterns of acceleration and deacceleration curves, and then mapping it onto different symptoms like dissociation, and also looking at these fine-grained differences in the heart, also really fascinating. And another dimension that we can look at is the neural representation of these interoceptive and bodily signals. And we can do this in different ways. I actually adapted this slide based on the discussion this morning and added in this extra part, which doesn't relate to FND, but we were talking about symptom amplification. And I put this in as I thought I wanted to give you an indication of a neural marker of potentially symptom amplification. So just focusing on the heartbeat itself changes the neural representation of the heart in the brain. So we have something called the heartbeat evoked potential. We can look at it with EEG. It's a neural measure where the amplitude of this signal in the brain is a measure of the neural response to the heart. And just paying attention to the cardiac signals amplifies the signal. So if we have someone who's hypervigilant, focusing on bodily symptoms, then just the nature of those neural representations when focusing on those signals is going to be changed and amplified. So you get these very interesting dynamic interactions with attention and neural representation of these internal signals. And then work that I've started collaborating with in terms of Hinda Yagaraja, who's a really talented neurologist, and Samira, who is his PhD student, who's in the audience right now. I don't want to give it away too much because she's been awarded one of the talks tomorrow, but I just want to highlight this work because I'm really excited by it, which is looking at this heartbeat evoked potential signal in the brain and looking at how it changes just before a functional seizure. And actually you get these fascinating differences in heart-brain integration in this marker of neural signal connected to the heart that is different just before a functional seizure and not an epileptic seizure, and Samira will be talking about that more tomorrow. But looking at not just neural activity, but neural activity that's integrated with physiological signals gives you a new window into seeing how there may be differences in different neuropsychiatric conditions. And now I'm going to jump onto a different dimension, which is interoceptive accuracy, which is a behavioural measure based on the precision with which people have accuracy into their internal bodily signals. And this is a measure that's being tested quite a lot at the moment. It's got a lot more popular, and it really differs between individuals. So you get some individuals who are incredibly precise about detecting what's happening in their bodies, and other individuals who are not precise. So this is a fascinating individual difference measure. Historically, it's been looked at using cardiac tests. These are very straightforward tests. For example, there's one test where you count how many heartbeats you feel in a specified time frame. We can look at how many heartbeats people report relative to how many they actually had and create a ratio. And this gives a measure of people's interoceptive accuracy. This has been criticized a little due to the potential influence of higher order measures. There's another test that we can use, which is much more stringent and much more difficult, where we play tones in sync with people's hearts or out of sync with their heartbeats, and people just need to make synchronicity judgments. But that's a very, very difficult task. It's based on internal, external integration, but it can't be driven by any higher order measures. It needs to be driven by interoception as well as exteroceptive processing. And we know from seminal work done by Hugo Critchley all the way back in 2004 that if we scan people while they're doing these tests, you get nice individual difference measures in people's accuracy. Some people are good, some people are very poor at it. And this variability in people's behavioural performance is correlated with both their activity in this right anterior insular region and also the grey matter volume of this very same region. So now we have a structural measure and a functional measure in this right anterior that correlates with how good or poor people are at these interoceptive tests. And because it's a big debate in the literature, trying to find different interoceptive tests and more precise interoceptive tests, if for anyone who's interested in this debate, I've just edited a special issue dedicated to interoception methods with Manos Sakiris and Andre Schultz, which is out now. So in addition to looking at individual differences in accuracy, we can also look at reported beliefs about the body and how good people think they are at interoception. And just to sort of give a sort of theoretical point is I think interoception has developed in a very different way to exteroception. So exteroception allows us to know something about the outside world. So typically, if we're attending to something and it's above a certain threshold, then we'll typically know if we've seen it, felt it, heard it. Whereas in terms of interoception, our brains are being bombarded all the time by internal signals. And sometimes these rise to consciousness, but a lot of the time they're pre-conscious. But that means that there's interesting divergence between conscious access and interoception, and they're more uncoupled than they are for exteroception. So you get this interesting a situation where beliefs about the body and what the body's doing don't necessarily map onto accuracy measures. And I think that's so important when trying to understand about symptoms and symptom reporting. And you see these greater divergences between self-report measures and accuracy measures in different clinical populations. I'm going to zone in on autism as an example of this, as this is one of the groups that I'm currently focusing a lot on at the moment. So as I'm sure you all know, autism is associated with difficulties and differences in understanding their own emotions and emotions in other people. As well as I'm sure you know, anxiety is very, very highly comorbid. And in the clinic in Sussex, where I was affiliated, we were seeing sort of 60% of autistic adults also having an anxiety disorder. It's very common. And then from an interoception perspective, this area, this insular area, which is involved in this neural sensing of internal signals, is its activation patterns and its functional connectivity is very different in autism. So in terms of functional connectivity, the degree to which the insula co-activates with other areas in the brain, you get reduced functional connectivity in autistic individuals. Put very simply, it acts more like an island, this area that's key for bodily processing and also emotion processing as well. And something I categorically disagree with is it has been said that autistic individuals lack empathy. I do not think that is true at all. Yes, you might get different neural patterns. Sometimes you get differences in report patterns. But as long as people understand, then actually I find empathy to be very high. And when you see the body, you actually get a very strong story about empathy and autism, which is autistic individuals actually have higher bodily empathy than non-autistic controls. A study which shows this is one by Gu et al. So it wasn't my own, but I've sort of fascinated by it, and it shows that if people who are autistic or healthy controls are watching other people in pain, actually the autistic individuals have a higher skin conductance response to seeing other people in pain than non-autistic control individuals. And the skin conductance response to the pain of others can be seen as a bodily empathy response. And this wasn't just overactive skin conductance to all stimuli, it was selective to pain stimuli. And it made me wonder about whether there was a difference in the way that autistic individuals are processing these bodily changes, and did they have impaired interoception in some way. And if I had longer, and if this was a talk devoted to autism, I could also talk about how there are a number of other features of autism that are also potentially associated with interoception deficits. Intuitive eating, hunger is an internal interoceptive cue, and autistic individuals sometimes forget to eat. They're not maybe getting the hunger cues in the same way, or maybe they really like a food and they overeat. Maybe they're not getting the fullness symptoms in the same way. Intuitive decision-making can be guided by internal bodily signals, and autistic individuals will sometimes take a very rational perspective, and maybe they're not getting these internal bodily signals in the same way. And emotion processing is influenced by the perception and sensing of internal bodily signals. And we also know a presentation of emotion can be different as well in autistic individuals. And these are all consistent with the idea that something different could be going on in terms of interoception in autistic individuals. This was the first study done looking at interoception in autistic adults. So I hypothesized that individuals who are autistic would have reduced interoceptive accuracy as ascertained on these straightforward cardiac perception tests. However, I was also aware that in the clinic, autistic individuals would often say they were overwhelmed by bodily signals. So it's not that they're not sensing them, it's maybe they feel sometimes like they're bombarded with them and they feel overwhelmed by them. So I hypothesized that in contrast to the reduced interoceptive accuracy, they would have heightened self-report measures of interoception, showing this potential double dissociation. And that's what we observed behaviorally. So when we give these straightforward cardiac perception tests, at the group level, the autistic group, and each person is red, you can see that there's a difference at the group level, but it didn't extend to every autistic individual. It was just some who were very impaired in this interoceptive accuracy relative to the control individuals who are here in black. And this fits with what we know about sensory alterations in autistic individuals. Some have extraceptive sensory changes, but they're not uniform in all individuals. They're quite selective, and this is just saying that interoception is an extra sense that may be altered in some autistic individuals. And this accuracy measure, the behavioural accuracy, contrasted to the self-report measure of how aware are you of interoceptive sensations. And actually, at the group level, the autistic individuals said that they're very, very aware. So you get this higher awareness, but lower accuracy measures. I then wanted to look at this in terms of an error score. So if we Z-score these measures to put them in standardized space and subtract them to look at awareness, self-reported awareness relative to accuracy and precision, to look at this error term, then we can see that it correlates with anxiety. And so this led me to hypothesize if we could make people more accurate, close that error between reported awareness and lower accuracy, could we reduce anxiety symptoms? So as an initial proof of control pilot study, we just wanted to see whether we could train individuals to be more interoceptively accurate, and could we then see corresponding drops in anxiety. And so we had 8 training sessions, and this is very straightforward. We just got people to do very, very light exercise, maybe a few star jumps on the spot, just so people could feel their heart beating stronger and faster. We then repeated these short interoception paradigms with them, where they count their heartbeats, or they notice tones in sync or out of sync with their hearts. This was done while their heartbeat returned back down to rest. And we were able to tell them whether they're wrong or correct, to give them extraceptive feedback, and they're getting interoceptive feedback from the heart being stronger and faster due to the exercise. And we repeated this over 8 training sessions, and then we tested their interoceptive accuracy and their anxiety at baseline before the training, midpoint, which was halfway through, and then at the final point after the 8 training sessions. And we compared this interoceptive training group to a non-trained control group. And we can see that we were able to increase interoceptive accuracy. This was with the simple counting task. I don't find this compelling. It could have been influenced by higher order knowledge of heart rate. But I do find this data compelling, which is the internal-external integration task of judging whether tones are in sync or out of sync with your heart. The tones are always presented at the same rate, so there's no way of doing this task based on the rate of tones alone. And we used a stringent D-prime signal detection measure, and we were able to show that at the group level, we were able to increase individuals' interoceptive accuracy. Moreover, we saw drops in anxiety. Our drop in trait anxiety was significant at the group level, and our drops in state anxiety were coupled to the increases in interoceptive accuracy performance, both on the counting task and on the internal-external integration task. So the more interoceptively accurate people got, the more their anxiety dropped. In addition, we also saw two other variables that predicted drops in anxiety. And this was ascertained using the MAIA, which is a questionnaire about bodily monitoring. One measure was elevations in the not worrying scale, and that's based around the fact that if you notice a sensation in your body, do you worry about it? And actually, the more people didn't worry, the more their anxiety dropped. And also attention regulation, the more people were able to selectively focus on their body or on the world. This attentional control measure was also linked to drops in anxiety. And so this tells us that there's really three things which are important. There's interoceptive precision or accuracy. There's the attribution of the interoceptive sensations. You want to be accurate into those sensations, but you don't want to worry about them. And the other one is you want to have attentional control. So anxiety and depression are very much associated with a focus on the body, and that's not healthy. You need good attentional control to focus on the body when needed, but the world the rest of the time. So we brought this proof of principle study into a registered clinical trial in 120 autistic individuals, and half of these were trained on interoception, just like I said before. We called this group the AD group, aligning dimensions of interoceptive experience. And in a subsample, we scanned their brains before and after the interoceptive training and looked at changes in anxiety. And then in our active control group, we looked at prosody training, which is recognizing sentences in terms of the emotions that's expressed in them. And this is because autistic individuals will often say they feel very anxious, not knowing how someone else feels. So we wanted this to be an extraceptive training condition that would help alleviate their anxiety through greater emotional understanding. And we looked at anxiety. And we were able to make our interoceptive training group more accurate using these cardiac tests. So our interoceptive training group is the AD group in red. They were more accurate on the stringent D prime measure. And then this one, this is my favorite graph. Like, I don't know if anyone else will like it as much as me, but it's a self-report measure. So this measure is just saying how aware are you of bodily sensations. And what I find wild, and I genuinely think this is really profound, and anyone who finds this as interesting as me, please talk to me about it. So what we found was that the more accurate they were, they dropped their reported awareness of bodily sensations. So it means they then said that they were less aware of things going on in the body after they had increased accuracy. So there's something about greater precision and accuracy into bodily sensations that then means they're popping less into consciousness and people report being less aware of them. And I think that's deeply profound for symptom reporting, that if we can increase people's precision into the signals, maybe they report them less. Okay, and then in terms of our primary outcome of anxiety, we were able to show that on the group level, we got a significant drop in anxiety in our interoceptive training group. The effect size was 0.3 for those who are interested. And then we just unblinded the 1-year follow-up, and it stayed, and the effect size was 0.29 after a 1-year follow-up, which I'm thrilled about. But you can see even though it was significant at the group level, there was a lot of variance, and we actually had a predefined threshold that we registered ahead of time as clinically meaningful, which is a drop of 6 points on the STAI, which is only a 20-point item. And we, according to this threshold, and it was below a score of 55, we were able to show that 30% of our interoceptive training group recovered. And in terms of the pre-post scans, so what changed in the neural connectivity as a result of this interoceptive training, we found greater insular functional connectivity. So the insula is this key area involved in the processing of internal sensations, and we found the right insula to be more coupled with this VMPFC area, which is a laser, which is involved in sort of regulation of emotion. And we found left insular activity to be more functionally coupled to this anterior cingulate region, which is involved, which is another arousal signal in the brain. So what I think this interoceptive training is doing is it's helping autonomic control, and it's helping align in the brain different signals, arousal signals, so you're getting more coherence. And then I'm just going to read you some of the reactions to this. This is from autistic individuals saying how they felt and what their experience of it. One individual said, as the inner channel gets clearer, the outer channel gets more quiet. And they were alluding to a reduction of sensory overload that they felt with the clarity of the interoceptive channel. And this makes me think that processing the self, the body and the world is a bit like a seesaw, where you're either dominated by things in the environment or things in your body. And if we can increase the clarity of the interoceptive channel, this individual at least felt less overwhelmed by external senses. And someone else said, when I notice the impacts of anxiety on my body, I'm more aware of them and I'm able to reassure myself that it's just a physical reaction. So that's the not worrying part. I am better able to take deep breaths and trying to slow my breathing and heart rate down rather than letting it spiral. And I think this speaks to how early access into what your body's doing allows you to employ regulation strategies. It's much easier to calm yourself down if you're just noticing your heart ramping up relative to if you're already in like a full-blown meltdown. And then someone else said, I believe it's increased my awareness of hunger, and as a result, I remember to eat, drink, and go to the toilet. So in the interoception world, we're debating to what extent these different bodily axes are related, and this suggests or hints maybe that training on one axis may generalize to other bodily ones. So I'm almost out of time, so I'm going to whiz through. So implications for new treatments. I've just focused on the heart, but actually there are all of these different interoceptive systems in the body. And I wanted to flag an article that I wrote with the brilliant Camilla Nord, where we're looking at different bodily axes and relating them to interoception mechanisms which may underlie different mental health conditions and maybe routes for the treatment of mental health conditions. Just to conclude, I talked to you about these different interoceptive levels, which we can systematically study in the lab, see how they're different in different neuropsychiatric conditions. And interoception can be delineated across these different levels and in these different bodily axes. Some of these levels correspond, some of them are dissociated, and sometimes these dissociations can be greater in different clinical conditions. A comprehensive normative understanding of these different levels in different bodily axes will allow us to see how they're selectively altered in different clinical conditions. And it's my hope that these insights will also open the avenues for new treatments. So thank you to the funders, to the lab, and thank you all for listening.
Thank you. So brilliant talk. We started a bit late, so we might have time for one question. But before we do that, I'm just going to make up a new prize which will award you, which is the BMPA medal for the most enthusiasm for a graph. So maybe it become a recurring. It's very impressive. So any quick question before, but we might come back for more questions if there's time, because obviously both speakers have got complimentary talks. So there's a hand up at the back. Alan, I can see.
Thank you. I did enjoy your talk, and I did think your graph was profound, so I'll speak to you by asking a question. You don't have this sort of problem with interoceptive accuracy, and I know you're looking at it in the context of autism, but one strongly suspects this is present in quite a lot of contentious conditions, thinking of chronic fatigue syndrome, long COVID, etc. There's reasons to believe that might be a problem. And really, the question I wanted to ask you was where your profoundness takes you. Because the political mantra of the moment is that patients are expert in their own body. But perhaps what your data is showing is that people aren't expert in their own body, and that's the fundamental problem. So how do we take that forward?
So, and that's why I really want to highlight all of those dimensions as interoception, and beliefs is one of the dimensions, and beliefs can deviate. So I think the beliefs are valid, they're valid to the individual, but they can override and shape veridical input. And it's about trying to find, and it's difficult, and it depends what the veridical input is, and the heart's an easy discrete signal that we can monitor, and actually the other signals are more diffuse. But one of the things we need to do is get better tests and better ways at looking at beliefs and veridical input and how they might diverge, take the heart as a good proof of principle that they can diverge, and then see where that takes us.
Great. Thank you very much again, Sarah. Fantastic talk. Thank you.